Thank you all for coming today. It's really a pleasure to speak with all of you. I'm going to start by telling you a little bit about myself. I am a pulmonary and critical care physician. I still see patients in Chelsea, affiliated with Beth Israel Deaconess Medical Center. And there, before I came into this role as director of the Center for Climate Health and the Global Environment, I founded an institute focused on lung health at the BI. And over the last 10 years, I've done research identifying preventable causes of impaired lung health with a focus on translating those findings to clinical care and policy. I also want to share a bit about my background, which had a really big impact on my career over the last 10 plus years. And that was by getting engaged through my professional society, the American Thoracic Society. When I was just a junior faculty member, I joined their Environmental Health Policy Committee. And through that committee, got very involved in translating research on environmental exposures, especially air pollution, to national ambient air quality standards and climate policy. So you can see here a picture, that's actually a pretty old picture of me testifying in front of a Congressional Committee on Carbon Regulation. I currently sit on the policy committee of the ISEE, the International Society for Environmental Epidemiology, and I sat on the US EPA Clean Air Scientific Advisory Committee until last week. So I'm going to tell you a bit about research to begin, and to warn you, it's going to be a bit of a whirlwind. I'm hoping to tell you a bit about the work that I've done, how I got to where I am today, the pivot I'm making both as a researcher and as a center director to focus more on interventions at the clinical level, at the policy level. And then I want to end with a discussion of my vision for sea change and a group discussion, I hope, on how your department could get involved. So first of all, I know you're not all air pollution researchers, so I want to tell you a bit about air pollution. What does every picture in this image have in common?
Smoke.
Smoke, yes. And what creates smoke? What process? It's in the title. Combustion. Yeah, not all it's not all fossil fuels burning here, but something's burning, right? That's generally the source of air pollution, whether we're talking about gases or particles. And even though in this picture you're seeing a bunch of pictures of a lot of smoke, generally what I'm talking about is invisible particles and gases. Fine particulate matter, I'm sure you've all heard of. That refers just to the size of the particles, 2.5 microns in diameter. It's a commonly used EPA image showing a human hair. And if you look at the little red dots, that's the size of PM2.5. That's the size range of combustion particles, carbonaceous particles, metals. And they're small enough that they deposit all the way into the alveolar sac, so the lung where gas exchange takes place. Nitrogen dioxide is an invisible gas. It's produced whenever fossil fuels are burned, whether we're talking about traffic or natural gas burning, power plants, even indoor gas stoves emit nitrogen dioxide. And this is a picture of Toronto, just because I thought it was very illustrative. NO2 is a good marker of traffic when you measure it outside. And you can see here in Toronto that it aligns really neatly with where the roads are. It's also a precursor to another important pollutant, ozone, ground level ozone. Although way up high, it protects us from UV radiation. You don't want to breathe this stuff. On the ground, it is this gas is very toxic. It's a well-established respiratory irritant, and it's complicated because it's not emitted directly through fossil fuel burning, but it's a secondary pollutant. So when nitrogen oxides and VOCs interact in the atmosphere, especially under sunlight, UV radiation, that produces more ozone. And that's why it's also important when we talk about a warming climate. So I'm going to share some work on these pollutants, but I also want to introduce the concept of looking simply at how close you are to a source. Because, as I just explained, fossil fuel combustion emits a lot of things. And sometimes it it's rather than trying to parse out exactly what the pollutant is, it can be more meaningful to look at simply how close people are to a given source. So here, illustrating that for a busy road, this is a freeway in LA, and you can see that the concentration of gases, carbon monoxide, and particles, black carbon, are exponentially higher really close to the road, right? And then it dissipates down to background levels a few hundred meters away. And it's really hard for models to capture that level of precision, but a distance to a road is a distance to the road, right? And so you're capturing that whole mixture of pollutants when you look at it that way. And in the state of Massachusetts, the transportation sector emits almost 40% of greenhouse gases. So here's a cohort study I've worked in for quite a long time. Project Viva, Emily Oken is the PI. I worked closely with Diane Gold on this work. And what's special, I would say, from an environmental health standpoint for this cohort is the moms were pregnant in the late 90s. So the babies were born, 2000 to 2002. And so that's just when the US EPA started monitoring and regulating PM 2.5 consistently. So we've got good exposure data for these kids for their whole lives, and they're now young adults. And as an adult pulmonologist, I think it's important to point out that childhood is really important for respiratory health because the lungs are continuing to grow as kids get older, and then they reach peak lung health, the peak size of the lungs in your early 20s. And that's when so I don't know if there's any folks in the room in that age group, but you are at your peak for lung health, and then after that it's all downhill. And so it's really critical to look at childhood because that's the opportunity to optimize that lung health. And so this is some of our work in Project Viva, looking at air pollution in different ways. So if you look at that lower axis, proximity to road, that's just looking at distance to a road. The next one is looking at the prior year of fine particulate matter using a satellite model from Joel Schwartz and his team. And then at the end is a different kind of model using different methodologies, a land use model of black carbon. And black carbon is in the fine particulate matter size range, but it's more specific to traffic pollution and especially diesel fuels. And so what I think is striking about this is you got two different geospatial models, you got distance to road, they're looking at slightly different things, but you see a very consistent pattern here. And these effect estimates are comparing kids at the 25th percentile to the 75th percentile, equivalent to having lung function that's about 6 months delayed. That's one way to put it in context. We also looked at asthma, and the kids who live really close to a busy road in that 100-meter zone where it's exponentially higher had 3 times the odds of asthma compared to kids living further away. And in Project Viva, as others have found, kids with atopy, allergy, or family history of atopy, or allergic sensitization had enhanced sensitivity or greater effect estimates. And this has been seen in a number of different studies, kind of suggesting that allergy and combustion pollution kind of work together to irritate the airways. I was part of this workshop that was led by George Thurston, where we tried to put together all the evidence, the mechanistic, the clinical plausibility, the epi evidence, and came to a consensus that traffic pollution in particular and combustion pollution is a cause of childhood asthma. Until then, EPA just recognized that it exacerbated asthma. But from a public health standpoint, new onset disease is a much bigger burden on public health. I want to pivot now to a different exposure, also very relevant for asthma. When it's warmer outside, and also when carbon dioxide levels are higher, the pollen season is amplified and prolonged. And that's very easy to see. You can just look at the records of the pollen season in the Northeast, for example, and it has been steadily getting longer. And here is an image from a Nature Communications paper showing the trend in maximal daily pollen projections compared to the historical average. And you can see that the Northeast U.S. Has a lot of orange and red maps. Nick Nasikas is a pulmonologist, one of my mentees, who's done a lot of work on this. He got the actual pollen data from a Salem monitor and plotted it here, so you can see that there's some, as expected, some big seasonal trends here, big spike in tree pollen concentrations in June, and then a peak in the ragweed in the fall. And he looked at a different kind of respiratory measure, exhaled nitric oxide, which is used as an indicator of a type 2 inflammation in the airway. It tends to be a pretty good measure of eosinophilic inflammation in particular. And he found that in Project Viva, so these are generally healthy teens, that higher levels of pollen measured in New England were associated with higher exhaled nitric oxide, suggesting more eosinophilic inflammation. I would say that that's not a particularly surprising finding, but consistent with what we'd expect to see. And another important exposure here in the Northeast is precipitation that's really changing. The northeastern U.S. is expected to receive more rain, and more rain compared to the trends in other parts of the country. And so he used a weather model to look at exposure to rainfall in New England in Project Viva, and found that the kids who were more heavily exposed to precipitation, it does include snow, but most of this is rain, had a higher exhaled nitric oxide, so more eosinophilic inflammation. But why would that be? I mean, I don't really think of water as being particularly toxic. I have one more slide on this. He actually also found greater effects in kids who had asthma. So why might this be? Well, rainfall does increase actually acutely pollen levels, fungal spore production, and mold. So it's possible that it's through these mechanisms. And Nick actually has a K23 that's looking more deeply at these questions and measuring exposure in the household. Now I want to shift a bit more towards adults. I mentioned that ozone is a weather-sensitive pollutant, and it's predicted that we're going to experience, all else being equal, higher ozones as a result of ozone concentrations as a result of more hot, sunny days. And this is work that I did very early in my career with Murray Middleman, who's in your department. He was my mentor when I was a fellow. And we put our findings in context of the EPA Air Quality Index. I hope everybody's familiar with that index. So it is publicly available, airnow.gov. It tells you what the air quality is, where you're living. And in addition to looking at linear associations between, a certain increment in pollutant and lung function, we just compared compared lung function in adults who came in on a day when the air quality was green versus yellow. So that's still within air quality standards. But according to the US EPA, an AQI in the moderate range is acceptable, but perhaps of concern to susceptible. It's acceptable, but perhaps of concern to susceptible populations. And so here we got generally healthy, middle-aged adults in the Framingham Heart Study, and we compared moderate versus good air quality days. And we found that for all three of these combustion-related pollutants, lung function was worse on a moderate day. There was no evidence of a threshold effect for any of these pollutants, meaning lower levels are associated with better lung function, controlling for confounders. And the effect, the precision is a little bit lower here for ozone because we focus on the ozone monitoring season to try to really make it more directly translatable to policy. We found that obese adults had a greater association with ozone than non-obese adults. And I want to highlight this because there's a lot of evidence to support this. Mechanistic work led by Stephanie Shore here in mice. Also other cohort studies in the US and Europe, the normative aging study here, have all found this pattern. And it seems to be driven by IL-33. It seems to be a real difference. So I just think that that's worth noting. Because I'm talking to the epi department, I thought I would talk a little bit about confounding. So the paper that I just shared, comparing the air quality index, when people came in and what the air quality was. So we were looking at air quality measured by right on the roof of Countway. You can see it actually. That's it. That's the PM. That's the PM monitor on the roof of Countway. For ozone and NO2, we use the EPA monitors. And even though that is a very simple study design, I think it's elegant in that your personal characteristics, your socioeconomic position, is not going to be a common cause of your exposure and outcome, right? It's not going to. It's hard for me to imagine how those things would predict your exam date for the Framingham Heart Study. So there's less concern for confounding for the results that I just shared with you. It gets a little bit tricky when we're talking about long-term exposure, which is kind of a bigger deal, right, over time and leading to chronic disease. So I've done a lot of work looking at, together with a lot of faculty here, looking at models of particulate matter exposure. For example, here, this is a map of that satellite model, and you can see how it tracks with the highways in New England. And we've looked in Framingham, we looked at lung function. We also tried to look at actual tissue of the lungs using chest CT scans. And so I mentioned that decline that happens after your 20s. So here we can see, looking at that decline between the repeated measures of the Framingham Heart Study adults, we found that those were more heavily exposed to combustion pollution, PM 2.5, and living closer to a road had more rapid decline in their lung function between exams. And if you compared that group that was in that 100-meter zone and that plume of gases and particles compared to further away, that difference in decline rate was equivalent to the effect of having smoked tobacco. And 5 milliliters per year. That's something that adds up over time. I'm going to whiz through some other findings. We looked at tissue scarring, something called interstitial lung abnormalities on their CAT scans. This is work that I've done in collaboration with folks at the Brigham, looking at chest CTs and making a determination about this scarring. And I think it's important to note that a lot of occupational lung diseases are caused by exposure to dusts and fumes. And this is what actual images look like. So you can see, even though I'm not talking to pulmonologists here, you can probably appreciate that scan, especially on the right there, that's showing a lot of scarring, a lot of white. That's not normal. The scan on the left there, it's supposed to look black. Air is black on the CAT scan. So we looked at change between these CAT scans and those who are exposed. And we found a higher odds of having that kind of scarring and a higher odds of progression between scans in those who are more heavily exposed to traffic. So traffic just keeps coming up in these New England studies where traffic is a predominant source of pollution. So implications, very near roadway exposures are not directly monitored or regulated, but appear especially harmful. We found associations with asthma and wheeze, lower lung function, and more rapid decline. I didn't show it all, but some air trapping and evidence of emphysema among former smokers and the interstitial lung abnormalities. But in adults, one of the challenges is that people aren't carrying monitors with them everywhere. And so you have to depend on models to estimate what their lifetime exposure was. This is true for kids too, right? And I mentioned how we have that in Viva. For adults, there aren't many studies that have that and allow us to look at cumulative exposure, not just to these pollutants, but many other things in the environment. And I wanted to share with this group, there's a cohort study that I'm a co-I on, in which we're trying to do exactly this. It's the American Lung Association Lung Health Cohort. It's funded by NHLBI. We're more than halfway through recruitment of 4,000 young adults at that peak lung health age. And so the idea is that we can evaluate some of the determinants of impaired respiratory health before chronic disease sets in. And so we're going through great length to get their lifetime exposure histories or their lifetime address histories from when they were born, so we can link it up to different exposures. In another line of work, I've tried to get a little bit more specific to my patients that I see in clinic. And a lot of what I've been showing is modeled data. So in this work, we collected actual exposure, and I got a very motivated group of patients with COPD to carry these monitors with them everywhere they went for 4 months. And then they had to report their symptoms every day. And this is the study design. So we had them come in, we measured their lung function and symptoms, and then we followed them for a month, gave them 2 months off, another month, and so forth, to capture every season, and then nested some other studies that I'll tell you a little bit about, trying to look at more useful clinical biomarkers of exposure. The statistics for this study were complicated because of the correlation between observations, because we've got these only 30 people, but each person provided 120 observations in these correlated months. So we did 3 different levels of clustering. And I can't show you all of the work that came out of this, but some of the highlights are that we did find associations with those same pollutants in lung function, especially in those with higher eosinophil levels, which is a kind of indicator of allergic inflammation. And as a clinician, I'm always hearing, doctor, I have a really hard time breathing when it's hot outside. And I was curious to see if we would actually find evidence of that in this study. So we looked at outdoor temperature, we looked at personal temperature using these monitors. And here you can see what you'd expect, that personal temperature doesn't have as much seasonal variability, right? People have air conditioning for the most part and heating indoors, but outdoors you see this big difference. And we found exactly what I hear from my patients, that when it's hot outside, they have more trouble breathing. We didn't find big differences in lung function, but the symptoms were definitely worse. And when we looked at, let's see, one moment here. Yeah, this is summer outdoor heat. So when we're looking at what people actually measured, what the temperature was in their personal monitors, we found an association, even in the cold season. I mean, the confidence intervals cross the null, but especially in the warm season. I'm not going to share all of my work with the biomarkers, but I'm very interested in thinking of ways that doctors can identify high-risk patients to target our interventions. And I've done a lot of work sampling the respiratory tract. Here's a picture of that. It's called nasosorption. It's really an alternative to nasal lavage, or even more aggressive, like getting an induced sputum sample or bronchoalveolar lavage, which you could never do clinically. But this is really easy and non-painful, and you can measure cytokines. And I've done some exploratory work looking at metals that are linked to air pollution. And we did find in this exploratory work higher levels of lead and vanadium and copper in those with more higher particle exposure. So this is informed. Now I'm going to transition to interventions. And some of this, not all of this, is describing research that is already taking place. Some of it is describing work that I think is needed. This is my clinical trial. So the findings in my COPD patients carrying the monitors really led to this trial, where we're focusing on the eosinophilic COPD patients. These are the same people that pulmonologists are targeting with inhaled steroids and even more expensive anti-eosinophilic drugs now. And we're randomizing them to real or sham air purifiers. And in some ways, this is a climate intervention. It's removing combustion particles, it's removing aeroallergens, it's removing mold from the air, and also infectious aerosols as well. We've finished recruitment. I don't have results to share yet, but it's a really elaborate study. We're following them for 15 months, so we watch them for 3 months pre-randomization and then a full year after, so that we capture all of that seasonal variability and exposure. And we have so many other samples that we're collecting and storing, so this is also an advertisement. The study is going to be done in a year, and there's so much opportunity, so much we could learn from this work, I think. What about masks and respiratory protection. This is another issue that I think is really important that the medical field has not figured out, right? Who should be wearing what, where, and when there's a wildfire taking place, when we have these high pollution days. Should people with allergy even maybe be wearing respiratory protection in some situations during the pollen season? There isn't a lot of work on this. I was part of a NASEM committee during the pandemic that was grappling with this related not just to infections, but also wildfire smoke. And we made some recommendations. I think there's still a real gap there in terms of public health guidance. And during the wildfires of LA over the last few weeks, myself and my colleagues, we were getting so many questions about what should people really do. And I think we need to do more work in this area. Another thing that's been really motivating for me is wildfires and trying to help figure out public health guidance for this. This is a workshop that I was a part of before the pandemic, but it's still so relevant today. And what we highlighted were some of the research needs, and it's all around what are the effective public health interventions that actually affect behavior. You know, how do we respond and guide local efforts to address these hazards quickly? We recommended a federal investment in a national research program on this. I'm going to tell you a little bit about some research that we do have planned. Oh, this is the very next slide, actually. So Kari Naidoo and Joe Allen and others here are going to be working closely with partners in LA to do research related to the wildfires in LA. And what we're starting with is exposure assessment, but I'm hoping that this is going to lead to a lot of insights that will help the research community prepare and respond and help public health agencies respond to future wildfire outbreaks. Different kind of research is thinking about evaluating policies and whether they were effective and what the costs and benefits of them were. Of course, there's a lot of work in this area, and I think that more is needed. There's many studies. This here on the left is not my own, but many analyses have estimated the health benefits of carbon abatement measures in terms of air quality alone. So not through climate models and projections on weather and so forth, just looking at the short-term immediate changes in air quality. And those benefits are enormous and outweigh the cost of CO2 abatement. And I'm wondering if we could do more work that's more usable. That's the thing. I don't want to criticize this paper on the left. I think it's a really important point. But when you think about the local context and a city planner, for example, who's trying to make a decision, this is kind of too high level, right? And I think we need more work that's more tangible, that gives you these numbers on a scale that decision makers can use. And this is not it here on the right, but this is the start of it. So Stephen Mean is a pulmonary fellow who's worked with me, and he did this follow-up in Project Viva where he looked at the change in air quality. So in Boston, actually, we've had improvement in PM over the last 10 plus years. And so he looked at the relationship between the improvement in PM and the change in lung function. And the kids who had more improvement in air quality had faster lung function growth. So that's encouraging. Like, can we translate that into estimates that decision makers can use? Final research example, this was led by Kevin Cromar. And what he did was organize a group of investigators to do a meta-analysis on estimating the impact of temperature on mortality in a way that could be used by the US EPA in the social cost of carbon. So, there's lots of research on heat and mortality. And until before this, the social cost of carbon, which is what is used not just by the US EPA, but also internationally in some settings to estimate what the social cost of carbon is generally not really considered health. It included some effects on occupation and other things, productivity, but not health. So this was just the beginning, but I think it was a really inspiring example of someone who really understood what were the metrics that were needed to inform this estimate, right? How does the social cost of carbon work? And he generated the estimates in a way that was useful for the decision makers. So then it was used by the US EPA and incorporated in the social cost of carbon. So, I think I still have time. Oh, good. So now I want to pivot a bit towards sea change. And my vision for sea change is that we're going to be a global leader in solutions-oriented climate, pollution, and health research. And that work will include evaluations of interventions and policies at the level of patients, their doctors, hospitals, communities and cities, and also national and international governing bodies to address the health hazards of fuel combustion and climate. And as part of that we're going to help engage students at all levels through education and research mentorship. And not just at Harvard Chan, not just at Harvard Medical School, but university-wide. I'd really like us to help elevate this work, help make connections, inspire research in this direction. And so to get there, we're going to have to do more than what I did for the last 10 years, identifying problems, right? All that research I showed you was showing you, air pollution in this way, and this way, and this way, and the different outcomes. But I think now we need to think more about interventions and solutions. So more intervention studies and trials, more use of quasi-experimental methods, implementation of behavioral science, more cost-benefit analyses, healthcare delivery science, thinking about clinical care and practice, and engaging with communities and decision makers. I'll give you a few examples of what is ongoing and the team that we're building and the structure that I'm putting in place, and then I would love to have some discussion with the group. As I was interviewing for this job, the timing kind of worked out well that this center was funded. I ended up from Beth Israel submitting together with Kari Nadeau and Chris Golden this center proposal focused on solutions for climate resilience and health. And we're one of, I believe, 20 such centers that were funded. And we're aiming to develop sustainable and scalable community-based solutions focused on heat stress. So not focused on pollution as much as an emphasis for this center, but there's 3 different research projects. One is in Boston together with a family van where we're trying to improve resilience against heat stress in the community and environmental justice communities around Boston. We're we're doing air conditioning intervention. There is another study led by Chris Golden in Madagascar focused on a cooling and fish storage solution in a community that has a lot of problems with spoilage of fish due to lack of cooling and refrigeration. And then the third project is in South Africa in a peri-urban setting. It's a cool roof intervention. So I'm really excited about this work, and this center in some ways is providing some infrastructure to reshape sea change. So a lot of the core faculty that are joining the center for this initial phase in the next 2 years are part of this center. So here's the structure that we formed. We've got 12 core faculty members, all of whom are very much pursuing research careers in climate and health and from different disciplines. We've invited anyone who's doing work on climate and health to be affiliated with our center, anyone in the Harvard community. And we already have almost 60 affiliated faculty members, but if any of you research scientists are also invited or interested, please join. It means that you'll be invited to our events, you'll get our newsletter, networking opportunities, and it's also a wonderful way for students to see what's happening because some faculty are doing some work in this area even though it's not the focus of their research. We have a steering committee, a scientific advisory board, and we're building a partners advisory board. Education is a major focus. We have a high school program. There's a fellowship led by Sachit Balsari and Caleb Dresser, who's pictured here, to educate and train clinicians. We have a concentration here that's open to any student at the school. But I also put a box here around our research network. We have a monthly seminar that's hybrid. All are welcome. So if you sign up or give Tracy's here, give her your email address if you'd like to be part of the seminar series. We'd love to have you join us. And here's our team. Amrita Nori Sarma is a new faculty member, came to us from BU, and she has expertise in data science. Chris Golden, as I've already mentioned, from the Department of Nutrition. Shobha Ramanathan, with expertise in implementation science and health services research. Marcia Castro, the chair of the Department of Global Health, who does work also in infectious disease and work in the Brazilian Amazon. Rachel Nethery is a biostatistician. Gaurav Basu, who's a clinician, primary care doctor, does a lot of work on education and curriculum development. Lisa Robinson, a research scientist at the Center for Health Decision Science, does a lot of work in cost-benefit analyses. Gary Adamkiewicz, who's working also in the P20 as part of the Family Van Project, he leads that, and he has expertise in community engagement and housing. Vanessa Carey, who's a WHO envoy for climate and health. Caleb Dresser, who's a clinician, emergency room doctor, and he does a lot of work on giving clinical guidance and preparing health clinics to deal with climate stressors like extreme heat and wildfires. Lindsay Burkhardt, who's a pediatrician and directs research for the Center on the Developing Child. And Nick Nasikas, who I've already mentioned. And I also just want to give a special thanks to Murray Middleman, who's part of your department. He's really just been a wonderful mentor and colleague and friend. So I believe he might still be traveling. But thank you all.